And trastuzumab deruxtecan surely, showed us 40 months, unprecedented.
Well, DESTINY-Breast09, very exciting data. Let's move to that. Dr. Javeri, tell us a little bit about DESTINY-Breast09, maybe summarize for us some of the findings in general and what struck you the most when you saw that data set.
Yeah, I think I can take a step back and talk about trastuzumab deruxtecan and antibody-drug conjugates. I think, our very first HER2-directed antibody-drug conjugate was TDM1 or etotrastuzumab emtansine, very exciting for solid tumors, with breast cancer being the first one where we saw positive data that really shaped our paradigm in the second-line metastatic setting. So we were using CLEOPATRA. We then started using TDM1. And then what we learned was that the next generation of antibody-drug conjugates were even better. And trastuzumab deruxtecan surely, showed us that data, and we had head-to-head trial comparisons, including in the DB03 trial, where we saw that T-DXd was way more superior than TDM1 and kind of, moved up the ladder in the second-line metastatic setting. So it was very natural for us to pick this agent and think about it. Can we bring it even further earlier line? And can we utilize it in the first-line metastatic setting with the idea that maybe using up our best therapies really upfront might have a larger impact, not only on progression-free survival, but also overall survival. And so that set the stage for DB09, where we tried to say, hey, can we use T-DXd? Could T-DXd alone replace THP? Could we think about T-DXd plus pertuzumab and then compare that to THP and see what the PFS looks like? And lo and behold, we did see that, despite our excitement and what we have been doing for a decade with THP, we did see a 40-month progression-free survival benefit with the combination of T-DXd with pertuzumab compared to 26 months, which we saw in the control arm, which is also better than what we have seen with CLEOPATRA. CLEOPATRA gave us 18 months, and it potentially could be because in CLEOPATRA, patients were not allowed during the maintenance phase of HP to get endocrine therapy, even though they had HR-positive tumors, which was approximately 50% of the patient population. We do that in practice, but the trial necessarily did not do that. 40% on the DB09 study did have endocrine therapy concurrently in the control arm, and maybe that's why one could explain potentially a longer PFS benefit in the control arm with 26 months, but 40 months, unprecedented, including 15% complete responses, which is really, really impactful, I think. So great data. I think it's nice to see this data. Certainly differences in that here we're doing T-DXd plus P until progression or toxicity. It's not like we're just doing an induction therapy the way we did with CLEOPATRA and then maintenance. We are giving this therapy the way we did in DB03. I think outside of the first-line setting, because of CLEOPATRA, in any subtype of breast cancer, we don't necessarily think about induction. We treat for progression and toxicity. So I think we have kind of just changed that in the first-line setting because of how CLEOPATRA gave us that, but because also of the quality of life that we talk about with the maintenance HP for some patients. So it's interesting with that. But I think the PFS is really impressive. It's good to see the data.
Absolutely. Couldn't agree more. And that was a very nice summary.